Hello and welcome to our presentation on the venous return curves from bench to bedside. Venous return is equivalent to cardiac output. The primary driver for any change in cardiac output in a patient with normal contractility is venous return. The venous return is determined by the pressure gradient from the flow to the right ventricle from the venous reservoirs. So the pressure at the venous reservoirs is higher than the right ventricular pressure. So this pressure gradient determines the amount of venous return that is coming back. It is highly influenced by small changes in CVP, blood flow distribution, and sympathetic tone. So coming first to the Starlings approach. In Starling's approach, what the experiment was done by Starling was he isolated the heart and measured the pressure in each chambers. He had a venous reservoir and the heart pumped the blood out, and through a capacitance it was sent back to the venous reservoir. So in this experiment he found that the left ventricular end diastolic pressure was linked with the stroke volume. So in this we can see as the left ventricular end diastolic pressure increases, the stroke volume increases. However, there is an upper limit to it, and if the contractility is low, then the increase in stroke volume also decreases with the increase in the left ventricular end diastolic pressure. So this primarily showed the significance of Starling principle, which means that if you consider a situation where the stroke volume of the right ventricle is 101 ml and that the left ventricle is 100 ml. Now it means basically that whatever blood is coming into the left ventricle must be pumped out. So if the Starling principle is not followed, then even if there is a 1 ml difference between the right ventricular pressure and the left ventricular pressure with a heart rate of 70 per minute, it will result in all the blood volume of the blood body coming into the lungs in the next 1.5 hours. So this is the significance of having the Starling's principle, that is whatever is coming in has to go out, and there must be a correlation between the right ventricle and the left ventricle. If it is not there, then the blood will start pulling, and even with just 1 ml difference you will find the entire blood volume in the lungs within 1.5 hours. Next is the important concept of venous return. These were experiments which were done by Guyton in isolated hearts. In this, it was found that the venous return is almost constant as long as the right atrial pressure is 0. Once it starts crossing 0 and there is an increase in the right atrial pressure, the venous return starts to come down. Now, various other experiments were done by Guyton to find out the mean circulatory filling pressure, the normal venous return curves, the determination of cardiac output through venous return. Before the Guytonian concept, the control of cardiac output was primarily considered by two terms, that is the heart rate and stroke volume. This is entirely based on the Starling's principles. However, he introduced the concept that systemic circulation and the return function of the heart is also equally important. Now, what we can see here is that the volume that is distending the veins and creates an recoil pressure that drives the flow back to the heart. So heart's basic function is to lower the pressures in the right atrium. So by lowering the right atrial pressure, it creates a pressure gradient from the venous reservoirs. So heart's primary function is a permissive function, which is to reduce the pressure in the right atrium. However, it also have a restorative function, which is the contractility function, by which it again fills in these reservoirs. So heart has two functions. The first is a restorative function to restore the venous reservoirs. The next is the permissive function, which is maintaining a gradient from these reservoirs to the right atrium. So heart contracts to reduce the right atrial pressures. Now, mean circulating filling pressure is a pressure in the vasculature when there is no flow and is determined by the volume that distends all of the elastic structures in the circulation and the sum of all their compliances. Flow occurs when there is a pressure gradient from the beginning to the end of the circuit, which here means the venous capacitance vessels and the right atrium. However, if the walls of this closed loop are non-compliant, which means that it's a solid pipe, then the pressure at the beginning will be same as the pressure at the end and there will be no flow. However, the flow can occur if some part of the circuit transiently takes up the volume and then releases it, which means that the venous vessels have some capacitance. They take up the volume and then release it. So under basal conditions, 30% of the total blood volume actually stretches the vessel walls and creates what is called the mean circulatory filling pressure, or what we call as the stressed volume. So as you can see over here, this is what is representing the heart, which is inside a pleural cavity. You have the right atrial pressure, you have the venous capacitance vessels. So when in the venous capacitance vessels, what we have is the mean circulatory filling pressure, and here we have the right atrial pressure. So it is the pressure gradient between these two which is causing the venous return. Heart's function is to keep pumping the blood out and reduce the pressure over here. Now if we draw our graphs, what we get is a graph like this. On this side we have the right atrial pressures, in this side we have the venous return. Now as we can see, it is independent of the right atrial pressure below the point of 0. However, as the pressure starts increasing over 0, the venous return gradually comes down. Where it meets the baseline is called the mean circulatory filling pressure. This is the pressure which is in the vessels when the heart comes to a standstill, that is, there is no circulation. This slope is determined by the resistance. So as the right atrial pressure increases, the venous return also increases. The next we have is the cardiac function. This graph is well known. This is the Starlings curve, the right atrial pressure and the cardiac output. Now if we superimpose both the graphs, what we see is on the left side you have the return limited, on the right side you have the cardiac limited, that is the contractility limited graphs. What we work out is during in this part. So where these two graphs cross is called the working CVP, that is the CVP of the particular patient which is actually being maintained. Now here it is shown in more details. So this is the venous return curve. The red represents the cardiac output, that is the contractility function. When the circulation comes to a standstill, what we get is the mean circulatory filling pressure, and the slope is determined by the venous resistance, which is calculated by the mean systemic filling pressure minus the right atrial pressure divided by the cardiac output, which gives us the slope of this curve. And the difference between the mean systemic pressure and the right atrial pressure gives us the venous return flow, that is the driving pressure for the venous return. This is the calculation for the elastance of the venous vessels, which is the mean systemic pressure minus the right atrial pressure divided by the mean systemic pressure. Now what we see over here is a patient in which we are giving fluid or having a reduced cardiac output. This graph over here represents the normal graph. If we give fluids, then the venous return increases because the mean systemic pressure is increased. This is caused by volume infusion. Now, the other method by which the cardiac function is affected is by cardiac contractility. If the patient's cardiac contractility is reduced, this is the normal cardiac contractility curve. So here you had a cardiac output. So after giving the volume, your cardiac output increased. However, if your cardiac contractility is reduced, then your increase in the cardiac output is less compared to patients who has a normal cardiac function, to patient giving volume infusion. Now, the mean systemic pressure has four determinants: two static determinants, that is the blood volume and the vasomotor tone, and the dynamic determinants are the blood flow distribution and the venous conductance. Now, the static determinants of the venous return, the first being the blood volume, it shows that this blue line represents the normal venous return. If there is hypovolemia, the mean systemic filling pressure reduces, thereby reducing the venous returns. And with hypervolemia, it is similarly increased. Now, what happens to the vasomotor tone? If we increase the vasomotor tone, we are increasing the mean systemic filling pressure, which will increase the venous returns. And if there is vasodilatation and there is more blood being pooled in the venous vessels, this will reduce the mean systemic filling pressure, and it will reduce the driving pressure for the venous return and will reduce the venous return. Now, is there any way by which I can actually measure this mean systemic filling pressure in bedside? There have been various experiments. We will try to see how various methods have been used over the years to find out the mean systemic filling pressure, especially at the bedside. Now, these are initial experiments which were done in animal models. The first was done by Pmsf in 1984. In this, they tried to use the positive pressure ventilation and the reduction in stroke volume associated with the inspiration. So they calculated the right atrial pressures, the stroke volume, and they made a curve out of it. In this, they tried to extrapolate where the line is crossing the baseline, which would give us the value for mean systemic pressure. In the calculation for this, as you can see, there are a lot of values in various patients if they had different types of curves, but overall statistically they found a very good correlation along the line with a very good statistical significance. Now, going further on this concept, concept of using an inspiratory pause during inspiration was used. Here similarly you can see the graphs changing, the stroke volume going down, the pressures going up in the airways, and this was again used to calculate the mean systemic filling pressures. And here you can see they are getting a value by plotting it on the graph. Now, these experiments were done in animal models. So the first experiment that was done at the bedside was done in the OTs. The authors, they tried to measure the mean systemic pressure at the bedside using a inspiratory hold. Here similarly, they took patients who were in the OT. They first did a head tilt to cause hypovolemia, and they gave a 500 ml fluid bolus resulting in volume loading. And with this they tried to draw the graphs, and what they found by changing the pressures in the inspiratory pause, and then they tried to calculate the mean systemic filling pressure. Now there is one more method, which is the measuring by stop flow technique. Here you have a radial arterial line, and what you try to do is occlude the vessels. So the point where the venous calculation and the arterial line come into an equilibrium is called the mean systemic filling pressure. Now this was done at the bedside also, and it had found very good correlation. Now, defining mean systemic filling pressure in ICU. Previously, all these studies have been done in the OTs. This was the first attempt to trying to do it in the ICU with the stop flow technique. And in this, they found very good correlations, and they found that the higher mean systemic filling pressure was seen in patients who had higher 24-hour fluid balance, vasopressor requirement, and mechanical ventilation. Now, this is a study in which they tried to find out the changes in the mean systemic filling pressure with volume challenges. This was in a setting of post-surgical ICU patients. So here they gave two types of volume challenge, and they tried to see how there was a correlation. They divided the patients into responders and non-responders. And what they found out was the patient was a responder if there was an increase in the driving pressure, which means that giving the fluid did not result in an increase in the right atrial pressure. If by giving the fluid there was an associated increase in the right atrial pressure along with the mean systemic filling pressure, then there was no difference in the two, and there was no driving pressure, and the patients were non-responders. So what we can deduce from here is that increase in the right atrial pressure with fluid infusion should be a stopping rule for giving fluids, which means that if you are doing a fluid loading, and what we are targeting actually is an increase in the mean systemic filling pressure, not in the increase in the right atrial pressure. If you're finding an increase in the right atrial pressure by giving fluid, it means that the heart is unable to cope up with the volume load, and it is resulting in an increased right atrial pressure. So this is where we should stop giving fluids. Now there are other aspects to this as well. We try to see the change in the driving pressure for venous return, defining the change in the cardiac output. Here, as you can see, first what we do is give a volume expansion. So with the volume expansion, what I'm targeting is an increase in the mean systemic filling pressure. So if in this type of patients, I am finding an increase in the cardiac output, it means that my increase in the mean systemic filling pressure is more than my increase in the right atrial pressure. So the patient is now a responder to volume loading. However, some patients do not respond, and what they need is a vasopressor requirement. So how does vasopressor help? Vasopressor helps by increasing the mean systemic filling pressure by increasing the vasomotor tone, and this increase is more than the increase in the right atrial pressure, thereby improving the cardiac output. And finally is the dobutamine. What dobutamine does is reduces the right atrial pressure by improving the contractility, thereby maintaining increased driving force and by improving the cardiac output. However, the vasomotor tone of the vessels is slightly different when patients are on vasopressors. So what happens is, if there is an increased vasomotor tone, it not just increases the venous return, it also changes the slope. So there is a slight change in the slope apart from the change in the venous return. So even though there is an increase in the venous return, the slope goes down. The opposite happens when there is a decreased venous return. The slope becomes more steeper as the venous return is reducing. So this was experimented at the bedside in patients who were septic and on decreasing doses of NORAD. So what first they did was, on high dose of NORAD, they tried to find the venous return curves. Then they decreased the NORAD and they measured the venous return curves. So before the reduction in the noradrenaline dose, the mean systemic filling pressure was higher than what was actually found out later on, which shows that even though there is an expected decrease, the slope of the graph also changes. This type of change is also seen with the effect of dobutamine. Here in this graph, you can see increase in the slope of the graph as the vasomotor tone is decreased by dobutamine. As you can see over here, the graph becomes more steep. So trying to find out how exactly dobutamine improves the contractility function and the venous returns. So here is a normal graph. You have the venous return, you have the cardiac output, and this is the resting CVP. Now what happens is, once I give dobutamine, my contractility improves. So the increase in contractility will increase my cardiac output. So my cardiac output has increased and my CVP has gone down. However, the actual cardiac output increase seen with dobutamine is much more higher. Now, how does this happen? This happens because apart from the increase in the cardiac output curve, it also changes the slope of the curve, which shows here that this graph, as the vasomotor tone goes down, the graph becomes more steep. Thereby, a more increased cardiac output is seen when you are giving dobutamine. So this has two functions. The first is improving the contractility. The second is by reducing the vasomotor tone and decreasing the mean systemic filling pressure. The both resulting in a much higher cardiac output with dobutamine. So to conclude, venous return is the primary determinant of cardiac output in most of the patients, because the contractility function is not something which is changing minute to minute. Even if the cardiac contractility is reduced, it is in a steady state. So with a steady state cardiac contractility, the factor that actually determines the cardiac output is not the contractility function of the heart, rather it is the venous return which is coming to the heart, which is altering the cardiac output. The next important thing to understand is that ventricular function defines the mean circulatory blood volume necessary to maintain this steady state by setting a right atrial pressure. So what the heart does is, heart reduces the right atrial pressure by increasing the cardiac output, and by reducing the right atrial pressure, it is increasing the driving pressure of the venous return. Now the cardiac output can only increase if the actual venous return increases or the venous resistance decreases. If the venous return to increase, we need a higher driving pressure. That is, there must be a higher pressure from the mean circulatory filling pressure minus the right atrial pressure. So I have to increase the mean circulatory filling pressure, which I can do by using vasopressors or fluids, or I can reduce the right atrial pressure. So overall, we can use these concepts for our resuscitation in shock patients, and as our lectures go, we will find out more how these concepts can be used at bedside to improve the hemodynamics of patients who are having shock. Thank you for your patience.